Wanted to give this talk about trying to prepare for what the future might hold for people who are living with dementia. I know that staying at home is a very high priority for many people. And so it's helpful to know relatively early on what kind of problems you might encounter so that we can get out ahead of those, because that is the best way to keep people in their homes. So there's no disclosures. I will talk about a couple of products, but I'm not making any specific endorsements of this brand versus the other. These are just kind of the ones that I know of. So kind of two biggest things we'll talk about are the more practical sides of staying at home, really boots on the ground situations that you might encounter, and then the more financial side of things, which is also difficult for people to stay ahead of. So this is just kind of a list that we'll go through of what are the most common issues that people run into when they're trying to stay in their homes at different stages of the illness. And this is kind of true regardless of what type of dementia someone has. It's certainly more common in some types, some issues may be more common in some types of dementia than others, but any of them can be seen in any type of dementia. So wandering is a pretty common problem. Sometimes early on, kind of cues that someone might be at high risk for wandering is if they are very restless, moving around a lot, especially at certain times of day. They might say things like, I need to go to work, I need to go home, even though they're at home. Sometimes people get confused in the evening. People who have difficulty navigating inside the house are also more likely to accidentally go outside and have trouble finding their way back in. So door locks are probably the easiest thing that you can do. Everybody has locks on their door, especially if they are above or below eye level or kind of difficult to maneuver. That can be helpful if they're physically complicated to get open, but never lock someone inside the house alone, because if there is a fire or an emergency or something unpredictable, they cannot get out. So it doesn't work to just lock someone in the house and leave to run to the grocery store. But if you're in the house with them, having the locks on can slow them down if they're trying to leave. Door alarms are also good, or even bed alarms if somebody's at high risk of falling and you need to know if they get up in the middle of the night. Downside of that is it can be disruptive to the family because then you have to wake up and kind of go deal with it. But is certainly better than someone getting outside and getting lost in the middle of the night. It's helpful to have tracking devices either on someone's shoes. People frequently put on their shoes before they go outside, even if they are confused, if they're sitting by the door. And also in the car, especially someone in a more mild stage of dementia might still feel like it's okay for them to drive, even if it may not be, or even if they are driving most of the time, but not supposed to be driving at night, or not supposed to be driving in high traffic areas. So it's good just in case someone is out on their own, even if they're supposed to be out on their own, if they do get confused or turned around, to have those as resources where you can find the person again. Having a wallet card or a medical alert bracelet is good so that if someone, if they come across someone, if they're asking for help, if they seem confused, especially a medical personnel will know to look at that and see this person has memory problems. We should contact the person on the medical alert bracelet and try to help them get home. Other things, if you know that the issues usually come at a certain time of day, if it's every morning, they want to get up and go to work, they don't need to go to work, maybe you find something at home for them to work on, so that they still feel like they're doing their task, they're still doing that obligation that they've always had, but are not trying to leave the house to do it. Similarly, a lot of times people have trouble in the evenings as it starts to get dark. People tend to get more confused, or get up overnight, try to find the bathroom, can't find the bathroom, and get lost that way. And then if you are out in public with somebody who has memory problems or trouble navigating, it's a really good idea to stay kind of close to them, and just kind of keep eyes on wherever they are. So if they go to the bathroom, watch for them to come out. It's very easy to get turned around in somewhere that you've never been before. Falls and mobility problems, this can happen at any stage. It certainly becomes more common as disease becomes more advanced. Um, but if anyone has any underlying problems like arthritis or weakness or balance issues, this can come up at any time. Physical therapy, if someone is having trouble transferring, so that's kind of getting from bed to a chair or from chair to toilet, physical therapy can help teach how to do some of those transitions safely. There's also a home safety evaluation that you can request that will look at things like picking up rugs off the floor. Are there any thresholds that somebody could trip on? Is there anywhere that grab bars should really be to help someone kind of pull themselves up off the toilet or not slip in the shower? There's also a lot of assistive equipment, like more than you could possibly imagine. If someone is very resistant to using an assistive device like a cane, which certainly does happen, especially if they've been very healthy or very athletic their entire lives, they might not feel like they need to use one. So it can be kind of hard to convince somebody at some point to use them. Building habits early, just so that someone kind of has that right at hand. You can leave different canes or different walkers around the house so that they're really easy to get to. They don't have to remember where it was or track it down. Trying to get in the habit of that early. There's also different types of devices. Some people really don't want to use a cane because, I don't want to look like an old man, but they might be more willing to use hiking poles or a walking stick that I think look kind of cool. You can decorate canes. You can get them in different colors. They don't all have to just look like, that standard boring metal walker. You can really personalize them and make people a little bit more willing to use them. Also, if somebody is prone to kind of standing up and moving around without assistive equipment when they really need it, you can get bed rails. The downside of that is sometimes people can get their feet stuck in the bed rails, so you need to be a little cautious with that, but that's a decent way to help keep people in bed. There's also different types of chairs and things that are just difficult to get out of if you have trouble standing, and if someone physically can't get out of a chair, then they're not going to go anywhere and fall. The more advanced assistive equipment is things like hospital beds. Hoyer lifts are for people who are a little bit bigger, where you kind of need to put a sling underneath them, and then the machine will help pick them up and transfer them. So if somebody has kind of special needs in that way, those are things that you can try to acquire. Usually something you need to talk to your doctor about. You're not just going to be able to pick those up over the counter at any old medical equipment store. Agitation, unsafe behaviors are really, really a big breaking point for a lot of people. Unfortunately, this is not uncommon, and it can kind of come out of nowhere sometimes. Although often there are warning signs that the people might be ramping up, getting confused, getting frustrated, acting out a little bit. Generally, if someone in the house has memory issues or impulse control issues, removing or securing firearms is very important. Even if somebody used to be an avid hunter, maybe they're very familiar, very comfortable with firearms, at even relatively mild stages of dementia, that might not be as safe for them to use independently. So just making sure that that's all kind of accounted for. You can also do something called it's formally called a functional behavioral assessment, but the idea is just to try to figure out what is someone trying to communicate when they're acting out. Behavior is a way to communicate when you can't do so verbally, when you can't express what you're feeling. And so often triggers for agitation are things like pain, boredom, anxiety. Maybe they're hungry, maybe they need to use the bathroom, maybe they're scared because they feel like they're lost, they feel like they're not in their home. So you can kind of assess if you have a behavior that's happening multiple times, what happens before it, what happens during it, and what happens afterwards, to try to figure out what are the triggers that can cause this and what are the responses that work best to calm it back down. So you don't have to do that, totally formally, but that's the general assessment that we would try to do to manage a behavior. Therapeutic fibbing is, I think, kind of a difficult pill for a lot of people to swallow. Nobody wants to feel like we're lying to our loved ones, but it's more just joining someone in their world. If someone truly believes that that picture on the wall is not their picture, that's somebody else painted an identical picture and put it up there, you're not going to convince them otherwise. That's a fixed delusion. That's part of the disease. That's a symptom of the disease. And so joining them in their world, oh, we'll get the other painting back. That's just temporary, and then try to distract, try to move away from it. Other things, I had a patient who every morning wanted to go out and take care of her goats. She did not have goats, but she had goats when she was a little kid. She had to go out and take care of. So, if she wanted to do that at an inappropriate time when it was not a good time to go outside, family would just say like, "Oh, somebody else did that today. You don't need to worry about that," and kind of just go with it. You don't have to fight them on it. That being said, there are some things that you can't, that you do need to push back on, things that are unsafe, or things like, no, you didn't take your medications today, or, oh, well, you need to take these other medications. You can get as creative as you want, but, people need to take their medications. People need to be generally kept safe. If someone is responsive to reassurance of, no, that's not happening, don't worry about that, then that's fine, that works. But a lot of times you'll get pushback. And if you're getting pushback saying, no, that's not happening, try to meet them where they're at. And then distraction is your best friend. When all else fails, just try to find something else to do. Try to find something else to interest the person that you can go do together instead of focusing on the thing that's upsetting them. If behaviors escalate, which can still happen even if you're doing your best, there are people who have such regular behavioral disturbance that they have to be on some kind of scheduled medication. That's something you can work on with your doctor. But it's also good to have things on hand for as needed medications that you can give to somebody if they are starting to ramp up and you're having trouble kind of bringing it back for whatever reason. If they're not willing or able to take a medication that you just hand them, say, hey, I see you're getting a little anxious. Maybe you should take this and try to feel better. There are liquid medications. There are ones that can dissolve. You put them under your tongue. They tend to act a little bit faster. You can also crush medications and put them in food or drink. Just check with your pharmacist about any individual medication. Some of the longer acting ones or ones that are formulated in certain ways should not be crushed. So just make sure you ask about that before you actually do it. Usually the types of medications that people will be put on, sometimes antidepressants or anti-anxiety medications, especially for prevention of behaviors. Antipsychotic medications, although they do have some increased risk of cardiovascular side effects, like heart disease in older people, sometimes you just have to take that risk in order to help someone be more comfortable, less anxious, and more able to stay at home. And then also being very aware that if somebody has pain issues, that can cause a lot of agitation and discomfort. And so sometimes having someone on pain medications, Tylenol, if they can take it, an NSAID like ibuprofen, or even things like very, very low dose opioids in select cases can be appropriate. Sometimes there's a certain family member that can just always calm the person down. If that person's willing to be on call, great. So if there's somebody that they have a good connection with, unfortunately, sometimes there can be a lot of strain between your role as both a caregiver and a spouse, or a caregiver and a child, or a caregiver and a very close friend. If you're the person that's kind of with them all the time, that can come with a little baggage sometimes. And so sometimes getting somebody from outside the situation to come in and help can make all the difference in the world. And then if you're really just at your wit's end, the emergency department is better than getting hurt. If you get hurt, you can't help take care of them. If they get hurt, that's a whole other problem. And so, if we've tried everything and you have to go to the ER, or get 911 to come try to help them calm down, then it is what it is. It's not a first plan, but it is there if you need it. That's what it's for. Also, if this was a very sudden change, very dramatic change, where someone was fine one day and then the next day you find them sitting in the chair with a knife thinking that people are trying to break in. That's a pretty dramatic change. If that's not normal for them, it's worth checking. Urinary tract infection is kind of the classic culprit, but other things like electrolyte disturbance, sodium, or like blood salt being off, blood sugar being off, there's all kinds of things that can be wrong that they may not be able to express in any way other than getting more confused. So if they're in the emergency department, they can also check and make sure there's no medication side effects that could be causing this or any underlying illness that could be reversible. Sleep disruption is a very common reason for people to struggle to stay at home because sleep is extremely important for caregivers and care partners. It's important for the patient as well, but it is very common for people's sleep schedules to get flipped in dementia. And that can make it really, really difficult for the people living with them. Things to avoid is really over-the-counter sleep aids. Most of them are a type of medication that, yes, it will make you sleepy, but it can also make you more confused or can worsen fall risk. And we just generally discourage people over, about 60 or 65 from having those, and certainly anyone with a diagnosis of dementia or cognitive impairment generally should avoid the over-the-counter things. The exception is melatonin, which is a pretty good, doesn't work for everybody, but it's a pretty good medication. Generally pretty well tolerated. You can do anywhere between like 3 and 15 milligrams, just depending on what the person needs. Usually giving it a few hours before bed is the most helpful. It doesn't work like a classic sleep aid where it should make you sleepy right away. It's to enhance the natural chemical that your body already makes in those hours before bed that are kind of telling your body to wind down. Okay, it's nighttime. We'll be going to bed soon. Keeping a consistent evening routine. You always do the same thing before you go to bed. And then, okay, now it's bedtime. We lay down. Staying asleep can be a problem, though. So we'll talk a little bit more about that later. But staying asleep can be kind of its own problem. Avoiding evening naps can help people fall asleep and stay asleep better. Having the lights on during the day and then off at night, with the exception of night lights, specifically off when it's sleep time. You do want to have some night lights around in case people get up so they can see, they don't trip. But generally you want to keep it dark when you can. Motion triggered lights, I think, tend to be best because then they're not going to wake the person up, but they're there if the person is already woken up. And then during the day, just try to get out in the sun if it's nice out. If it's crummy, we live in Minnesota, it's not always going to be perfect. You can get a light box. That's what those are over on the right side. Like I said, I don't endorse any particular brand, but just something that gives kind of full spectrum daylight. Use it for an hour or so in the morning. It's good for mood to get that sunlight. It's good for energy, and it does help your body regulate the sleep cycle a little better. And then also check and see if there's any causes that are obviously making someone wake up. So if someone has known sleep apnea, if they're not wearing their CPAP, or if their CPAP's uncomfortable, if they have a history of acting out their dreams, like kicking or punching or jumping out of bed, that can certainly be a problem. If someone has a lot of pain at night that can wake them up, I hear a lot about hip pain or back pain or hands falling asleep. That's something you can work with your doctor to try to help manage those symptoms. People with restless legs often have trouble falling asleep, or people who need to use the bathroom a lot overnight sometimes have trouble getting back to sleep, and also are more likely to get up and kind of wander around at night trying to find the bathroom, have trouble getting back to bed. Speaking of kind of issues with the bathroom, incontinence tends to be a barrier that a lot of caregivers understandably can't cross. Urinary incontinence is one thing, maybe you can help dad change his diaper, but bowel incontinence is really, really hard for a lot of people. It's just very uncomfortable for someone to do that for their family member or their loved one. If that's a line that you can't cross, that's not a judgment of you, but it does mean that you'll need to have some help doing that if the person wants to stay at home. You'll need to have somebody kind of consistently on hand for if there is an accident. Now, scheduled toileting can help avoid accidents. So, hey, every 3 hours, we're just going to get up and we're going to sit on the toilet and we're going to see what happens, kind of like right before you go on a road trip. You can also try to be mindful about when you're scheduling certain types of medications. So, a lot of these anticholinergic medications, you don't have to worry about what they're actually called, just ask your pharmacist, are used to prevent people from urinating too frequently. So oxybutynin is the biggest offender that I see. There are some alternatives that are less bad for cognition, but just be cautious when you're using those urinary function medications to try to reduce bladder activity, that can actually cause more problems than it fixes. If somebody's got a water pill or diuretic that's going to make them urinate a lot, don't give that at night. If you are taking medications for constipation, try to take that at the same time every day, depending on how long it takes to be effective. Maybe that's a morning thing versus a night thing. It just kind of depends on the person. If someone is having a lot of overnight need to use the bathroom, and they're able to use something like a bedside urinal or a commode, sometimes that's easier, causes a little less sleep disruption if you can just roll over, urinate in the urinal, or stand up, go to the commode, and then get back to the bed. You don't have to go so far, it's right there. Or even a condom catheter. They don't work anatomically for everyone, but they're pretty much exactly what they sound like. You roll them over the penis, they kind of stick there, and then any urine is collected in there instead of kind of leaking through. They don't work for everybody, but could be an option. I was recently told at a conference I went to that if you put the head of the bed up like a couple inches, not far enough that you're sliding out of the bed, but just a little bit, so there's a little incline, it can supposedly reduce the need to go to the bathroom at night. So if anybody wants to try that and get back to me about how well that actually works, I would love to hear about it. But that's the new hot tip that I'm investigating. And then having the right equipment, adult diapers. I know it doesn't feel great to talk about adult diapers, but they are very important. They are less uncomfortable than they used to be. And I think, just make sure they're sized correctly. Get one that the person is willing to leave on. Taking them off can be a problem. Make sure you've got wet wipes. If there's a big accident, sometimes getting straight in the shower is just the easiest thing to do. But you can kind of try to prepare yourself so we don't get in a little bit of a crisis mode. And then 24-hour care, I think, is probably truly the biggest barrier, because it is just almost impossible for someone to be there, for one person to be there 24/7. And for people who were very independent, who are living alone, who maybe don't have a spouse, or are used to being left alone, this is hard for them too, to know that there has to be somebody around all the time. Like, it can cause some resentment. It logistically is challenging. So splitting care with any family members or friends, make sure that you're getting rest time for yourself if you are the primary caregiver. Even if that's just a couple hours a week, the grandkids are going to come over, the 20-year-old grandkid is going to come over and hang out while you run and get groceries. Like, that's still something. And the more of that you can get, the better. I'll talk a little bit later about trying to get in touch with things like PCAs or patient care assistants, volunteers who can just come over and spend time with somebody. It doesn't even necessarily have to be a nurse, unless somebody has pretty high medical needs. Sometimes it's just to make sure that somebody's in the house with them. And the reason for this, when this comes up, is mild stages of dementia, you usually have trouble with what's called an instrumental activity of daily living. So that's using the calendar, paying bills, these kind of high-level things that, yes, they need to be done on a day-to-day basis, but you can go a day without housekeeping. You can go a day without paying bills. So these people are usually able to live alone with assistance. When people start to have trouble with things like ADLs, just regular basic activities of daily living, things like bathing, toileting, remembering to eat, if they are wandering a lot, that tends to be when somebody's going to need more of that 24-hour care. If you're not sure whether someone needs 24-hour care or not, occupational therapy can do something called cognitive performance testing. They just run them through a series of things like show me how to make toast, follow these instructions to put pills in the case, show me how you would buy a belt. And then whatever score they get can estimate, whether they're likely safe to drive, whether they're likely safe to live alone with assistance, or if they are not safe to live alone. And those tend to be people who have trouble with, doing multiple things at once, really the more moderate to advanced stages, but it can be earlier than you think. So if there's any doubt, doing that cognitive performance testing is not a bad idea. My quick and dirty cutoff is that if they can't respond to an emergency, they can't be left alone. If you don't think that a person in a fire would know to leave the house and call 911 and be able to use their phone to call 911 or get to a neighbor to call 911, I would not leave them alone. Kind of other considerations that are, maybe not specific to keeping somebody at home, but can be a problem when you are trying to stay at home with dementia. Loneliness and boredom can really be an issue, especially if it's just you and your partner kind of in the house together. It can be harder to travel, both physically and emotionally is very exhausting, can trigger agitation for a lot of people. So if you have someone who's relatively social, an adult day program can be really positive for a lot of people. They can kind of get out and see people, do some activities, some positive stimulation. The people who are a little more advanced disease tend to have more trouble doing this, partially because it's harder for them to participate, but also it's harder for staff at day programs to manage medical needs. But this is a good option for people who are kind of on that border of, I'd really like for somebody to be there with them 24/7, but it's hard for it to be me. Home care assistants are people who can actually come in and basically spend time with the person. You can ask for more skilled caregivers if you need help with things like showering, toileting, setting up medications, or sometimes like family members or volunteers can just come and spend time with the person so that they're getting a little bit of company. Dementia toys can be actually a good response to agitation. So this woman's wearing something called a busy blanket or a busy apron. And it's just kind of covered with these sensory stimulation toys. Tends to be a little bit better for the more advanced stages, but people who like to mess with things or get into things sometimes find these appealing. Gives you something to do with your hands. They're very similar to the sensory stimulation toys used for like children with autism or other kind of sensory processing issues. But there are quite a few that are geared specifically towards people with dementia as well, including things like this cat. This is a little robotic cat. They also have a puppy. I think there's a bird now, and a seal was the original one. And they, make noise, they move. You can also get somebody a baby doll if they're the kind of person that just, loves babies and they just want to take care of the baby. This can bring somebody a lot of joy and a lot of purpose. You don't need to lie to them and say, yes, here is a real cat. But if they seem to not notice that it's robotic, if they want to treat it like it's real, if that's how they're interpreting it, those are often the people who will kind of have the best outcomes. So you don't want to force it on somebody, but it's often worth trying if you know that your loved one likes cats a lot or likes babies a lot and might want to spend time with one, but you can't actually get a cat or a baby. This is a good option for those people. Guided activities, so doing things with the person. A lot of times I hear people who are concerned, like they're just sitting watching TV. Sometimes that's all people want to do, and that's okay. But a lot of times if you try to get people up and do things with them, they will do them and they will enjoy them, and it's a positive experience, but it can be very difficult for people with dementia to initiate activities. There's a lot of planning that goes into that. that we don't even really think of as people without dementia. Doesn't, when you're doing your kind of normal day-to-day stuff, it doesn't necessarily occur to us how much goes into that cognitively. And so if you're doing things with them, that's often a lot more accessible to them. And then they also get that social component. Sometimes people want more stimulation, having music on or things. Sometimes people want less. So music can be calming. It can also be upsetting, especially if it's music that they don't like, or if it's a stimulation that they don't like somehow. So really playing it by ear a little bit and just trying different things and seeing what works best for that individual person. It's also worth knowing that apathy is a really common symptom. This kind of disinterest or unmotivation, people are not motivated to do things. So if you're trying to guide them out to activities or trying to, hey, let's do this, let's do that, and they just aren't really going for it, even when you're engaging with them, it might not be that they're having trouble, just that they're having trouble doing it. They may genuinely not be interested in it. And it's very frustrating for families. It's very difficult for families, but just know that that's okay. Sometimes people are just not going to be interested in doing different things, and that might be part of their disease process. So you don't have to force them to do too much. Sundowning can be a big problem. This tends to become more of an issue a little bit later on in the disease process. Can happen in people with more mild disease. Usually happens in the evening. It can also be triggered by big changes in schedule, like if you're out traveling. I've heard about some people who take an afternoon nap and they are less confused in the evening. I've heard about people who take an afternoon nap and they're super confused and agitated afterwards. So again, that's very much see what works best for that individual. Things that can help prevent sundowning is to keep a schedule that's regular, predictable. Keep your appointments in the morning if you're going out of the house, when people have more energy and are usually better able to tolerate it. And then often lower stimulation, kind of calmer activities in the evening will help people as part of that wind down process, and also can decrease the intensity of sundowning if people do get confused at night. This is a big time when behaviors can become a problem. So somebody who's basically normal themselves, does just fine during the day, can really, really struggle at night. And that can make it very difficult to stay home if you can't figure out how to manage that. So sometimes we'll schedule medications, try to identify and avoid any triggers for it. And then, if all else fails, we can manage, as in one of the previous slides, just kind of any other behaviors or agitation, medications, different behavioral response patterns, things like that. And then caregiver burnout is such a huge issue. And it's not a judgment on the caregiver. Like I cannot emphasize this enough. Asking someone to take care of another person 24 hours a day indefinitely, sometimes more than one person, if you've got kids and are taking care of a parent, for example, or if you're taking care of a spouse and a sibling, like that's just too much for any one person. So you do what you can. It's going to be stressful even if you have a ton of help. But if you start to feel like you're not able to take joy in everything is too much. Any little thing that gets added to your plate is just like something that feels like you can't cope with. That might be a sign that you're getting close to burning out. People who are at highest risk of this are those with lack of social support. If it's just you and your partner and your kids live out of state or family lives far away, people with challenging behaviors or a lot of personality change can cause a lot of burnout. There's a lot of emotional strain there. Like I said, people with multiple dependents, if you've got kids and a parent, or people who have their own medical things they're dealing with. If someone has a lot of chronic pain and heart failure, and they're also trying to care for their spouse with dementia and COPD, like that can be a lot to put on a person's plate. So just being aware that that's a thing that can happen. And if you lean into the supports that you can get if you try to access all your resources early. And hopefully, by hearing some of the things in this talk and getting out ahead of them, can avoid getting into kind of a caregiver crisis where you just reach that tipping point and you just can't do it anymore. That's kind of my goal here by talking about some of this stuff today, so it doesn't catch you off guard. Support groups can be helpful. One, it's just a place to kind of vent or commiserate, and knowing what to expect can be helpful. There are therapists who work specifically with people with memory loss or families of people living with memory loss. There are respite care programs. There are sometimes respite care assistants who can come to the house, or programs that will help you organize that. It's worth looking around, I think, and seeing what's in your area, just to get an idea of what's available so that it's there when you need it, or even before you think you need it. You don't have to wait until you're at absolute rock bottom, because that is when people are more likely to have to go to the ER. I can't do it anymore. We need to get you into a home now. And then usually there's, if you haven't prepared for that, it can be very, very traumatic for everyone. A little bit less relevant to staying at home specifically, but one more thing that can be distressing in more advanced dementia. People tend to have a decrease in appetite due to any number of reasons: medications, nausea, constipation, depression, all sorts of things. So find things that the person likes to eat. You can add color or texture if that makes it more interesting. You can do smaller portions and snacks during the day. You can get a swallow study done with speech therapy if someone's physically having difficulty swallowing things, if they're choking or having a lot of pain. And then sometimes changing the food or liquid consistency, either blending things, cutting them up. Thickening liquids can be helpful for swallowing problems. Snacks are also great. A lot of people have trouble remembering to take in enough fluids during the day, especially if you're one of the people that doesn't like to drink water, which I don't personally understand. I love to drink water, but there's a lot of people out there who do not. So foods that have high water content, like grapes or berries, popsicles, gelatin, are really good options. And then there are these things called jelly drops. This is a specific brand, although I'm sure there are other similar things designed specifically for people with dementia. They look like little candies, but they kind of dissolve in your mouth. I know they sound very interesting. So if anybody does have a personal experience with those, I'd be interested to hear it. But the goal is basically to try to give somebody something that's visually appealing, to try to get them a little bit more fluid during the day. Other snacks that are good, especially if people are losing weight, is protein shakes, or you can add some protein powder to things that they're already eating. The downside with this is it can sometimes make constipation worse, so that's just something to keep an eye out for. But that's much better for building or maintaining muscle rather than just adding weight. And then if somebody's having trouble eating due to tremor, there are weighted utensils that you can get, particularly for essential tremor. And for whatever reason, those seem to help people stabilize their wrist. It doesn't have to be super heavy, but just enough. And then at the more advanced stages, people do often have trouble using silverware at all. And so just having things that are kind of finger food, things that you can eat with just your fingers, or if someone doesn't have dentures that fit well or doesn't like wearing them, having foods that are soft and kind of easy to consume can help a lot with keeping someone's nutrition up. That being said, decreased appetite can also be normal. If you've tried all of these different things, you've made sure there's nothing causing low appetite. As people age, and especially as they near end of life, appetite kind of drops off. That's a very natural part of that process. So if someone is saying, I'm not hungry, I don't want to eat, if they just eat a tiny little bit at a time and don't really want to go back to anything, you're not starving them. This is a normal part of this process, and as long as you've made sure that there's no reason, no reversible cause for them not wanting to eat, then it's most likely a part of that dementia process. So you can always offer food, make sure it's available, but never force people to eat. That is their body telling them something, and they need to be allowed to listen to that body. Medications to increase appetite do exist, but they're not usually super effective. They might make people gain a little bit of weight, but it's not muscle weight. It's usually either water or fat weight. Not terrible if somebody wants to try. There are some antidepressants that can also help with weight gain, but just know that that's not by any means a slam dunk. And then feeding tubes in general are not recommended for people with dementia. Very few exceptions. Maybe somebody with mild dementia who had a stroke and is expected to recover their ability to swallow, but just to deal with poor appetite or difficulty swallowing, that's a direct consequence of dementia. They don't improve survival, they don't improve quality of life, and if anything, they can actually cause a lot of discomfort because there's this weird tube now suddenly sticking out of their stomach. It's very confusing, might not understand why, and putting food in or liquid in that their body isn't able to process can actually cause a lot of swelling. Fluid can back up into the lungs and cause trouble breathing. They might have diarrhea from the types of kind of liquid food that's given through a tube. So just for general knowledge, that is not something that we generally recommend for people with dementia. Medical considerations regarding staying at home. I think it's good to have an advance directive. I think it's good to have one early. This does only apply when someone is permanently incapacitated, but it does also allow you to designate somebody that is going to help take care of you. If the person needs a medical power of attorney, make sure that you have there's a different form for medical and financial powers of attorney. And I think it's worth taking time to fill out the section on values and goals. If someone doesn't feel as strongly about staying at home, maybe these are things that are not as important. Maybe it's okay to help someone get into a facility a little earlier, help them get adjusted, and get that extra support. If somebody really wants to stay at home, and that's very important to them, and they say, if I ever go into a facility, I want to just focus on comfort. If I can't be home with my family, I want to just focus on comfort. That's something that's important to know. Or if I can't do this, I can't do that, then I'm ready to reach the end of life. It's a very difficult thing to talk about, but I think it's very important to talk about early. There's also, for people who are big planners, there are dementia advance directives. What you want might differ depending on where you're at in the disease. So people with very mild dementia might want to have pretty aggressive medical cares, try to treat everything that you can. Whereas people might say, but if I ever get to the point where I can't feed myself, it's okay, let me go. So it can be a little overwhelming for most people, but if you or your partner is a big planner and that's something that you would want to go through, then that might be worth looking up. I'll put some resources at the end. There's also something called a post in Wisconsin or a post in Minnesota. This is mainly for emergencies, and it's particularly important for people who are at that point where they're prepared to focus mainly on comfort or at least avoiding heroic measures. Things like not wanting CPR or not wanting to be intubated. And so you can kind of choose your level of care a little bit, but that's an important thing to have, particularly if you're at home. And if someone does go to a facility, they will likely want one as well, or try to have that conversation at least. I think the most important thing for this is just to talk to your loved ones about what's most important. And if staying at home is on that list, then it's a good thing for them to know. But also I'll talk a little bit later about if that doesn't work for some reason, even if staying at home is incredibly important, sometimes life happens and you can't make it happen. You do the best you can. It's not a betrayal of the person. Sometimes we just can't predict the future. For people who want to die at home, hospice is a really good option. They also can serve people in facilities, but I think particularly if someone is kind of more severe, more advanced dementia, then having hospice earlier is going to give you a lot more support for managing those symptoms and managing kind of all the emotions around that as well. So don't need to go super in depth on this, but they do provide some additional home assistance, not full-time or residential care. There's 24-hour, that shouldn't say assistance, there's 24-hour like a call line that you can get advice, 24-hour advice. And some symptom management assistance and bereavement support. So that's a really good option for people at that very advanced stage if you've made it that far. And then just a couple slides on financial planning. I know this is really important for a lot of people because dementia care is expensive, whether you're doing it at home, whether you're doing it at a facility, it gets pricey very quickly. And so use your insurance if you have it. Standard Medicare does not pay for what's called room and board in memory care. So they'll pay for medications, they'll still pay for doctor visits, but they don't pay for the memory care itself, or same for assisted living, which can be a huge issue for a lot of people. They also don't pay for home assistance usually, just Medicare doesn't. If you do have long-term care insurance, a lot of people don't, but if you happen to, use it. Get to know what your policy covers, because many of them cover at-home care and also will help cover assisted living. Some of them only cover, will cover 5 years of care, or will cover up to this amount of care. But it still might be worth starting with that early, because none of us know how long we're going to live. And so if you can use that assistance when you start to need it, it's good to have that in your back pocket. Medicaid or medical aid usually have, in Minnesota, it's called an elderly waiver. It might be called something else in different states, that can help pay for care. This is usually only for people who are below a certain amount of assets. It feels very bad to have to, what's called, spend down. I know a lot of people save up hoping that they'll be able to pass some of that on to their family members, and they don't really want to use it to pay for nursing care or whatever else. You can sometimes set up a system to basically pay your family to be your caregivers. And so then in that way, that money goes to them. But I would work with like an elder care lawyer so that you're doing that legally and correctly, because there's a whole other set of considerations with that. Otherwise, basically, it's called spending down your assets until you are at the level where the person is on Medicaid or medical aid, and then there are some programs to help pay for care, including housing support, before someone is in a facility. And then if you have a health savings account or an FSA, a lot of things can be covered with that. So medical equipment of various sorts, adult diapers, like protein shakes, all that stuff can be bought using a health savings account. And so that's basically tax-free money. So if you do have that option, in the long run, it can save you a good amount. For some people, there are tax credits for, if you do have sharing taxes with someone who has dementia. If someone is eligible for VA support or assistance from a nonprofit, I know the ALS, Lou Gehrig's Disease Association, has a program to help provide support for people, just a one-time grant. So looking into things like that. Younger onset dementia might be eligible for penalty-free withdrawal from an IRA. You still have to pay the taxes on it, but there's not that 10% early withdrawal penalty if you can basically prove need. If you're still working, your work might have disability benefits. And basically anybody doing any amount of estate planning, dealing with any amount of money, or who thinks they might need to take on guardianship of the other person, it should have an attorney specializing in elder law or some knowledge of elder law. And then just kind of my tip, I go to a lot of estate sales and thrift stores. It's just something I enjoy, and I see so much pretty pretty good quality medical equipment being sold at those, because often people will get them, they'll use them for a little while, and then they'll either have to go to a facility or they'll pass away. Um, and then that's just there. So if you are kind of running on a low budget and want to look for things like that, that's a good place to start. One kind of critical thing is, in general, not just financial, but in general, is having a caregiver plan B, especially if you are the primary person, if you're a spouse and your kids are out of state again, or if you're an only child, don't really have a lot of help. What happens to the loved one if something happens to you? So you should get your own advance directive that names an alternative decision maker. Even with someone with relatively mild dementia might struggle in that very stressful situation to make an informed decision, and it's putting a lot of pressure on them. Certainly someone with moderate or advanced dementia who's not able to make their own medical decisions can't speak for you. So it's very important that you have somebody on your advance directive designated to be making decisions for you. You should also have a plan for where someone would live who would help them manage finances, appointments, and who would be their decision maker if you can't do it. And then even if your goal is to stay at home, I would recommend getting on the wait list early for assisted living or a facility, memory care facility. If you get to the front of the line, you can just say, no thanks, we'll wait, we're still good. They'll just send you back in the line. You are not obligated to move into a facility at that time. But it does help avoid that crisis point where you go, oh my God, we haven't even looked at anywhere and I am at my absolute wit's end. I thought that I could do this and I can't. So it's the wait list, especially for nice places, or especially if you have a really strong preference about where you're staying, trying to stay close to home. That's something that you should just be on the list for already. Memory care is not failure. Sometimes life just happens. Sometimes it ends up being a positive thing. The person will have more social and medical support there. It might be more enjoyable if someone is very isolated or lonely. It gives you the opportunity to return to being a partner or a child instead of a caregiver, which again can cause a lot of strain in that relationship. And if you get there and it's terrible, then you can find a different facility to move to, or if the situation changes, say someone wants to, is nearing end of life and really truly wanted to die at home, you're like, I can handle this for a month with some help. You can arrange to have somebody come home, for example. So it just depends on the situation. Things to look for in a facility, level of care. So if you do have a big multi-story house and you can't put everything on the same floor, it might be good to move to an independent kind of senior apartment or assisted living with step-down capabilities. So somewhere that has a memory care unit on the same campus, in the same area, so that if one partner needs to go to memory care, the other one wants to stay in the independent or assisted living apartment, you can still visit them easily. Check and see what services are available, if there are things that you need or just want. Location is important. You want to make sure if it's near family or near friends or just somewhere that you're familiar with, that you can actually find a place there. And then check for special allowances. If someone smokes, that can be hard to find a place. If you want to keep your pet, that can be really hard to find a place. I've also heard there are a few places that will let your spouse live with you, even if only one of you needs the memory care unit, but those are pretty hard to come by. So that's another reason it's important to start looking at that early. Even if your goal is to stay at home, you want that in your back pocket. You do not want that to sneak up on you, or you're going to end up somewhere that you don't want to be. All right, so that's pretty much all of the information that I had. I think you have kind of a list of additional resources. The senior linkage line is really good for Minnesota. I don't know of anything similar in Wisconsin, although there are plenty of community organizations that will often have resources. This is a link to an example of one of those dementia directives. There's several different types out there. If you just Google it, like lots of options pop up. It's not a legally binding document, but again, if you're a planner, it gives you some of the specific things that you might want to take into consideration for the future. And then this is a link to the housing support page for people who may have below a certain number of assets. Care ecosystem is somebody through our through health partners who will call you a variety of intervals. They're kind of revamping that system right now to have some different tiers of how much assistance you need, but basically somebody to check in and just see if you have any questions, are you having any issues, how can we kind of help you problem solve. And then we have a new social worker. We finally have a new social worker. So she will be giving, I want to say it's next month's lifelong learning talk. So you can look forward to that. And that's somebody that you can talk to go through all of those various resources, because there's a ton of them and they may or may not apply to you and your loved one. They can also do some education around things like how to respond to behaviors, what's normal, what's not normal. And then generally kind of coping strategies. She does some care partner support, but I don't believe she does extended therapy, but she will help you find someone who can do more extended therapy, if that's something that you're open to.